थोड़ी मेहनत करी थी जी याद नहीं करता है लगला शुरू से पीछे जो नहीं समझता था मुझसे बस शिक्षा की वहाँ कुछ
Hello everyone.
Good evening, sir.
Good evening. I think we'll start with Ekansh and then we'll have Shagun. So Ekansh, you should be ready with your slides. And I'll make you a host so that you can share your slides.
All right. Thank you, sir. Thank you, sir.
And others, please mute yourself. I don't want to mute myself. So Ekansh, we are absolutely on time. So I think we'll give another minute, maybe 2 minutes, and we will start. You can meanwhile share the slides. Can you share the slides or I'll have to do something?
Sir, I'm trying to. It says the host has disabled participants.
I'll just do that.
Okay, thank you, sir.
Can you hear me?
Right,
Ekansh,
sir.
can you? Yeah.
I can hear you. Right.
Yeah, please share your slides. Huh?
Yeah. Okay, sir. I'll try again.
Okay. Good afternoon, everybody. We'll start. And Ekansh, I can see your slides.
All right, sir.
I hope others can also see. So I would request everyone to type in the chat box rather than speaking that you can hear me and see me. And importantly, you can hear him as well as see his slides. So type yes if you can do both. You are able to do that. That's right. Okay. So yes, maybe a couple of people more would write it and then I'll start. Yes, they can hear me well and they can hear you too. So Ekansh, you can start making your presentation.
All right, sir. All right. Thank you. I'll just. Okay, sir. Sir, am I audible and is my slide visible?
You're audible and your slides are visible. If you want, you can switch off your video so that you can be, your internet would not be suffering. If you're comfortable that way, that's okay.
Okay, all right, sir.
Please start.
Good evening, everyone. Good evening, respected sir. Uh, um, I hereby present a case of a 33-year-old lady hailing from New Delhi, a resident of Manojpur, New Delhi, who is a beautician by profession. Belongs to a low to middle socioeconomic class calculated by the modified Kuppaswamy scale, with 50,000 being the per month family income. She presented to us with the chief complaints as follows. First, hoarseness of voice for 4 years. Secondly, swelling in the anterior neck for 3.5 years. Weight gain for 3 years. Difficulty speaking for 2 years. And shortness of breath on exertion for 2 years. Uh, Moving on to the history of presenting illness, the patient is a 33-year-old lady, urban dweller hailing from Delhi, who was apparently symptom-free 4 years ago when she noticed hoarseness of voice, that is for 4 years. Subsequently, 2 to 3 months later, that is for the last 3.5 years, she felt swelling in the neck. To be specific, it was pointed out to her by her husband. It was seen first. She visited a Sir, there's a disturbance. Sir, can you hear me?
I can hear you very well.
Okay, okay, all right. So, 3.5 years ago, she noticed a swelling in the neck. It was pointed out to her by her husband, who saw it first. She visited the government hospital, but no treatment was administered. The swelling has been there for the last 3.5 years. It is insidious in onset in the anterior aspect of her neck in the lower midline region, slightly towards right. It has been gradually progressive in size. There's no history of sudden increase in size at any point of time, and the swelling is not associated with pain. She feels she has gained weight in over the last 3 years, and so does her husband say. There's tightening of clothes. She's had to tailor her clothes suitably, and also she reports that she has gained from 50 kgs to 75 kgs over 3 years. In addition, she reports she has been feeling lethargic with generalized weakness and malaise being present for the same time duration, that is 3 years, in carrying out her not only her professional work but also her household work. Third, she has trouble in speech for the last 2 years. I won't exactly say so, but she says that she could sing. She was a bathroom singer. She can't sing anymore. She has pain in her jaws. She hesitates to speak, and like she it hurts when she speaks. Moving on, for the last 2 years, she faces shortness of breath on exertion. Before 2 years, she could climb up to 5 flights of stairs. Now she faces trouble climbing even one flight of stairs. Also, it can be it confirmed as her husband says that there is the slight punctuation of speech with longer pauses when she speaks now. Moving on, there is no history of pain in the neck, no history of pain over the swelling, no history of difficulty in swallowing food or pain while swallowing food. There is no history of swelling elsewhere in the neck. There's no history of fever. And lastly, there's no history of ptosis or loss of sweating on face on the same side, meiosis and ophthalmos. There's a history of oligomenorrhea for 1.5 years, though the cycles are regular, and she's not taken any treatment for the same. History of weight gain, as mentioned. History of lethargy for 2 years, as mentioned. She's having sleep disturbances for 1 year. She complains of insomnia. It could be because of the work suffrage, because of the COVID-19 scenario over the last 1 year. There's no history of tremors. And I further interrogated her. She says that she can write, and she can write the same way with no alteration. Also, she can thread the needle while knitting sweaters for her children. There is no history of palpitations. There's no history of excessive sweating or drying of skin. There is no history of cold or heat intolerance. And there is no history of difficulty in climbing few stairs or lifting weights like buckets during usual household work. To add, there is a history of exertional shortness of breath, as mentioned, with no history of shortness of breath at rest, no history of persistent cough, no history of abdominal pain or fullness, no history of anorexia, weight loss, no history of headache or blurring of vision, no history of any bony pain. Moving on, there is no history of irradiation to the head and neck region. She does not stay close to any region where there would be any nuclear exposure. There's no history of any prior surgery. She's non-diabetic, non-hypertensive, non-asthmatic. There's no history of ATT intake. In addition, there is no history of contact with any COX patient. There's no history of COVID-19 infection. She has history of long-standing constipation for 3 years. She on and off takes some laxatives for the same. And there's no history of diarrhea. And, she's had sleep disturbances for 1 year. She has a normal appetite though. She consumes a mixed diet, consumes 3 meals a day. There's no history of alcohol consumption and no history of tobacco consumption or smoking. There's a history of oligomenorrhea for 1 year, but cycles are regular. She has 2 children, both live and healthy, and she has had 4 abortions. There's no history of swelling in the neck among family members, no history of thyroid malignancy among family members. There's no history of MEN related malignancies among family members. To summarize historically, the patient hence described as a 33-year-old lady hailing from Delhi who complains of hoarseness of voice for the last 4 years, swelling in the anterior neck for 3.5 years, third, difficulty during speech, fourth, shortness of breath on exertion for 2 years, and finally, weight loss of 15 kgs over the same duration with lethargy, malaise, sleep disturbances. However, no features of hyperthyroidism and no compressive features due to the swelling and no features suggestive of metastatic disease.
So we're done with the history, very good history, but very exhaustive. And there are places where we were going unnecessarily overboard to make a point. So Ekansh, you must understand that to keep a track of the history is also important for anybody who's listening. Although I'm sure what you spoke was all true, but was it relevant? That's the question. Let's start from the first slide and we'll take it forward like we do every time. You can go to the first slide and we can get back. Ekansh, can you click on I think I'll reclaim that. Otherwise, there is a problem. I'm reclaiming, okay?
All right, no problem.
You can make your presentation. So we can now move on. Otherwise, I'll not be able to mute people. Some of them can create this problem.
All right, sir. All right, sir.
Now, let's take first slide and then we move on. 33-year, no problem. Now, actually, even you would notice. I put it down as 1, 2, 3, 4. Hoarseness, swelling, and then the other features. Okay.
Yes, sir.
Now, and you yourself mentioned that the swelling was noticed by the husband. So maybe the swelling was before that. Okay.
Yes,
you don't know.
Yes, sir.
Now, when you talk about this hoarseness, you need to be very, very careful. Now, is this the hoarseness which is of the kind that you observe in patient with sore throat or some neck problem, or the one which is due to recurrent nerve involvement? There is a difference. Can you tell me what is the difference?
The timber and the
yes, you're right. One is timber, then the pitch, and also this is the speech of a tired person. It's called a tired speech also. So that's quite different from, if I can understand from your history, the history is pointing towards somebody with hypothyroidism, as I understand. And you have the hoarseness coming before the swelling. I have no problem with that. You told me what she told you. But be
Yes.
careful to ask that question again. If the swelling came first and then came hoarseness, you're looking at a totally different problem. Then you're
All right.
looking at the cause of hoarseness to be the swelling itself, which is commonly seen with malignancies. Am I right?
Right, right, right.
So it is therefore necessary. So I'm going from the slide 1, therefore onwards. So this hoarseness for 4 years and swelling is 2 to 3 months later. So maybe the swelling was already there and she never noticed it.
She didn't
It's
know.
possible, no?
It's
So
possible.
we'll not spend a lot of time putting the hoarseness before deliberately, or even if she told you. I'm not trying to pull a fast one, but
All right, sir.
make it count.
Okay.
That's number 1.
All
Next
right.
is the swelling in the neck. Now, when you say swelling in the neck, it can be in the back of the neck also. Always say swelling in front of the neck,
Yes, sir.
because that's what you had, right?
Yes, sir.
And then you mentioned about I'm just sticking with the presenting complaints. Can you go back on the previous slide, please?
Yes, sir. Right.
And there's no rush. Don't worry. Relax. You made a good presentation. I'm just trying to make it better. Now, this is not necessarily necessary. She visited a government hospital or a corporate hospital. She visited a hospital for this, right? So no treatment was administered. So possibly she had no problem.
Possibly, sir.
So this hospital visit has any significance?
No, the significance could, what I was thinking at that point was that she had a problem, but probably she was investigated, but her investigations came out fine at that point of time. This is
Which is again not. I mean, she consulted. She took a medical advice.
Yes, sir.
Although she was found to be normal, but she's not normal. She has symptoms.
She has symptoms. Yes.
Yeah.
Yes.
So unless you find out something concrete, there's no point putting this hospital in this spot, because this hospital has missed it. That's what you would like. I would take from it. Next slide.
Okay. Yes.
Now, when you're giving the history of present illness, it's after you're finished with the presenting complaints, which you did. I have no problem with that. Swelling 3 to 4 months after appearance of hoarseness. You are insisting on it. And then you're saying she didn't notice, the husband brought it to her notice, which clearly means she would not have noticed even further. And which clearly means the husband had not seen, the swelling would have grown much larger. So it's possible, therefore, that the swelling was present when the hoarseness happened or before hoarseness. Is it possible?
Yes, sir. It's possible, sir.
Right. So for that 3.5 years, etc., don't make it exact, because you don't have to document it objectively when patient is not even able to make out that there was a swelling. Insidious in onset in the anterior part of the neck, center of the neck, you say, in the lower midline, slightly towards whatever, gradually progressive in size, no history of sudden increase in size at any point, not associated with pain. It's perfect. Next slide. Now, this is a significant history. She has gained weight in 3 years. And again, her husband has to tell her this each time. She did not know. She feels she has gained weight over the last 3 years. Tightening of clothes, need to tailor them suitably. Also, she reports gain of 15 kgs over 3 years, right? In addition, she reports that she has been feeling lethargic, and I think the whole story is of hypothyroidism. And you mentioned here, maybe it's not written there, that this was also noticed by the husband. Am I right?
Sir, the calculation she was not sure of. The 15 kgs figure was given by the husband, but she herself told me that she had to tailor her clothes.
So thankfully, she knew that she's gaining weight. This nobody had to tell her. That's okay.
Yes,
now,
sir.
Coming to this trouble in speech. Now, this is a very subjective term.
Yes, sir.
What do you mean by saying that trouble in speech?
So
you can be direct here. You can be direct here. That's why there's nothing like trouble in speech. You're getting what I'm saying? Because when you're talking using technical terms,
yes, sir.
She had speech disturbance, which was in the form of not being able to sing and pain in the jaws, both sides while speaking, and hesitancy while speaking. These are standard words. right? You don't have to make a lot of effort saying that she is a bathroom singer, cannot sing. Now she cannot even sing in the bathroom.
No, sir,
Which is,
sir.
that's okay. I understand what you're trying to say. You're
Uh,
basically trying to make it into hoarseness plus the pitch gone.
yeah, plus the pain in the jaws while speaking. Yeah. Yes, yes, sir.
And the tiredness of the muscles of the face to join
Right,
her in singing, especially complicated singing.
right, sir. Right, sir.
Okay, so basically both the recurrent and the extralaryngeal nerve, you think, which makes sense because in malignancy it's usually one, that is recurrent, which gets involved initially. So this would be
Right.
a general feature of hoarseness, which happens due to what is the cause of hoarseness in hypothyroidism, Ekansh?
Sir, it could be malignant infiltration of the or the
No, there
involvement
is no
of
malignancy. Hypothyroidism.
uh, sir, so it's because of the involvement of recurrent laryngeal nerve,
It is
uh,
not. Why should
or
the cancer get involved?
it's because of the weakness of the muscles uh,
Weakness of the muscles of what?
uh, the weakness of the laryngeal
Actually,
muscles.
larynx is where you speak from, right? Larynx, what's the problem? I've asked you a very simple question. And
Right,
also all the other muscles which are involved. So there is general lethargy. And that's why their voice changes.
right, sir.
Okay, they start their voice changes. Some people say like a goat. And moving on further, next slide, please.
Right, sir.
I think do read about what you're speaking because just don't try to make. Now you said she's a history of breathlessness or exertion.
Right, sir.
Don't have to expand, and you can say 5 stairs or whatever. You can't say she doesn't have it when she's sitting. I mean, breathlessness and exertion means that breathlessness happens when only the patient exerts. So what would that make out? It's a very heavily physician influence history where they make a lot of noise about minor points also. Here we are direct, no? She has difficulty or she has exertion.
Right, sir.
And you're trying to say that it has become a little more acute in the last few, what have you said, 4 weeks or whatever.
Yeah.
Also, husband reports punctuation of speech with longer pauses. So that's a tired speech, no? There is too much of tired speech. That's what it is. Next slide, please. These are terms which are important. You just otherwise giving a lot of material there.
All right, sir.
No history of
Here,
read it.
there's no history of pain in the neck or over the swelling. There's no history of difficulty in swallowing food or pain during swallowing. There's no history of swelling elsewhere in the neck.
Now you're wasting time. So there is no history of pain in the neck or the swelling or difficulty in swallowing. As if there is no difficulty in swallowing, there is no pain also. Pain is also a difficulty, mind.
All right, sir.
Don't make unnecessary, additions in this. Don't write rows here. There is no history of constitutional symptoms. No history of ptosis, loss of sweating on the same side. You're trying to make it very specifically into the sympathetic chain involvement. So no history of ptosis, loss of sweating. This is not there. So don't try to unnecessarily exaggerate it. Next slide.
All right, sir.
There is history of oligomenorrhea for 1.5 years, but for no treatment, and there is a history of weight gain without any change in appetite. History of lethargy for 2 years. You're already describing it here. History of sleep disturbance for 1 year. Complaints of insomnia. No history of tremors. She writes. That's it. If there's no history of tremors, she can write it. Now, while you're writing the rest, she can thread the needle while knitting the sweaters or while doing anything. She has no history of tremors. No history of tremors, palpitation, excessive sweating, or dry skin, cold or heat intolerance. No difficulty in whatever you've written here. Climbing, again, you've written no history of climbing in few stairs or lifting weights. You already described dyspnea on exertion. That's enough, no? And
Sir,
you also mentioned the stairs, how many she can climb. What do you want to say here?
here I was trying to rule out any proximal muscle weakness which could happen with
You added up there only. See, proximal muscle weakness is what is the feature, but then that should come in the same flow when you talk about the exertional dyspnea. What is the cause of exertional dyspnea?
Yes, sir. It's because of this. It's because of the same reason, right? Right.
What reason?
Sir, it could be because of proximal muscle weakness. It could be because of the weight gain. It could be
Yes.
because, yeah,
And carry on, I'm listening.
and it's because of the lethargy and tiredness of because of hypothyroidism.
So partner, read so that you can answer well. This is a case where everything relating to hypothyroidism will be asked. What is myxedema? Where all you find that the position of mucopolysaccharides, which deposit everywhere, and they can make breathing difficult, they can add to weight, they can make an extra gain in everything, bulk. So there are issues which you should have highlighted here. Next, I think there's a lot of repetition, and I'm just adding a few, and you can make it better. Again, you have written history of exertional dyspnea. You already mentioned it, haven't you?
Here I just wanted to rule out any
Don't waste
metastatic.
time, dear. You are wasting time. There's nothing there. You're just writing the same thing all over again here. History of exertional dyspnea. However, no history of shortness of breath at rest. You're making it, very elementary. Third year, fourth year medical student type. That you should not do. We understood, no? If there is a history of, there's no history of exertional dyspnea. Am I right? Naturally, so everything else is absent, no? If everything else is fine,
Yes, sir.
there's no history of abdominal pain or fullness. What do you want to say here?
There's no history of metastatic disease.
Is that leads to abdominal pain? And thyroid metastasis go to abdomen.
No lymph nodes primarily.
So what is this supposed to mean? Therefore, you're just unnecessarily writing things here without any idea. What is this history of abdominal pain for, sir?
Sir, they could be hematogenous.
Metastasis doesn't produce abdominal pain. Don't waste my time and everybody's time.
Right,
And it leads to no fullness.
okay, all right, sir.
I thought you read about it. You're just taking a lot of my time on very elementary things. The pain would be due to patient is constipated, there could be obstruction, there could be ileus, there are so many other reasons, and this history is not relevant, especially when it is absent. You already mentioned there is no loss of appetite, you repeated it again. There is no history of anorexia and weight loss. When you are giving me history of weight gain, why should I take a history of weight loss?
Right, sir. Right, sir.
I mean, you already told me that the patient has history of gaining weight. Yes or no?
Yes, sir. Yes, sir.
Then where is this? Where does it come from? No history of weight loss. When you're giving me history of, it's too very difficult to go through such a lot of text with no meaning. Basically, this patient has gained weight, is lethargic, there's a hoarseness of voice, there's a swelling in the region of thyroid. The rest, everything else you've just made up, and there's a waste of time. No history of bone pain separately, and then you're putting abdominal pain there and you call it that to be due to metastasis. I don't think it is making any sense. Next slide. Now, past history of exposure to irradiation is fine. No history of prior surgery. What prior surgery you are taking history of?
Sir, any neck surgery. She might have undergone some sort of neck surgery outside.
Outside or where? For what? How would that be connected to this? That's what I want to know.
So that would make our current surgical management difficult. It would lead to adhesions. Like
You'll do what?
it could lead to adhesions, and it could.
Adhesions. Where?
It could make up current surgery difficult if she has already undergone a
So you
surgery.
already decided this patient will need surgery.
No, if we in case we plan.
Wait a minute. Stop there. Why do we take history of any past surgery? What relevance would it have? I'm asking you a very direct question. Forget this adhesion business.
Sir,
You see, you are completely, you put the history in an absurd way completely. I'm sorry to say that. There is no connection between your, thoughts here. Any history of previous surgery, first of all, makes you understand, could that surgery be responsible for this problem? Could that disease be responsible for this problem? Is it possible that she underwent surgery for thyroid in the past and now she's got a recurrence of the disease? That is the relevance of a prior surgery. Diabetes mellitus, hypertension, and bronchial asthma are never a past history. This is a MBBS question. Because once a diabetic, always a diabetic. Once a hypertensive, always a hypertensive. So they don't become a part of past history. They become a part of comorbidity. Now you're writing no history of ATT intake. What is its significance here? And then you write no history of... I'm completely at sea. Your history taking has to go back to third year. I'm sorry. What is the significance of ATT intake here?
sir, there's no history of TB. That's what.
That's all you could have said. No. There's no past history of tuberculosis or contact with tuberculosis patients. That's it. Isn't it? That's what you're trying to find out. And what have you written here? No history of ATT intake. You should be able to make a technical impact on the person who's listening to your history. Next slide.
Right, sir.
Now, this is all right. You're talking about the addictions, about the diet, about the appetite, about the... you're writing 3 meals a day, normal appetite, mixed diet. No history of alcohol consumption. This is all right. Next slide. And she's constipated. Am I right?
Yes, sir, right.
Now, that distension could be why are they constipated? The patients of hypothyroidism are usually constipated. Can you tell me why? I think you present a case without reading about it. That is a very elementary question I was asking you. You will read about it. I won't tell you here. Coming to the menstrual history. Anything significant here? Oligomenorrhea. Yes?
Yes, sir.
And what is the significance of A4?
Sir, I could not relate it to this case.
Because you have not read anything about thyroid. What is the presentation of hypothyroidism in terms of menstrual cycles? Hypo and hyper. Tell me about both.
So both lead to menorrhagia.
Okay. What else?
And
both can lead to menorrhagia. And in thyrotoxicosis, you may have polymenorrhea also. Then in the obstetrics history?
yes, it's one of the causes of recurrent pregnancy loss.
What is pregnancy loss called amongst doctors? Amongst doctors, what is the technical meaning of pregnancy loss?
Miscarriages.
So let's talk like we are talking in a surgical class. Abortions or miscarriages. Making it so complicated. At one end you said, I don't know. And now you're saying it can produce infertility, it can produce abortions, it can produce menorrhagia, loss of... There can be many hypothermic features. There's so many features. They're given in your basic book. And you're presenting a thyroid case with features of hypothyroidism. So the least one would do is read about hypothyroidism. You can't expect it to be taught in an on-air class, although I've taught you just now. Those are the points that you need to ask in the history.
Right.
Don't waste everybody's time, and especially your time. I don't want to, I'm too scared to even ask you, why do they get abortions? What is the reason?
Right.
Okay, why do they get menorrhagia?
So there's early involution of the
I think I have a request to others to read before you make a presentation. Don't just casually walk into a classroom. This is too casual. You've not read about it and you've written a whole lot of unnecessary history because you don't know what to ask. Right? You're first year, second year, or a third year? Ekansh?
So third.
You're a third year.
Yes.
Let's go to the next slide. This is all right. You've taken a history of swelling in neck among family members, no history of thyroid malignancy among family members, no MEN-related malignancy among family members. So you don't need to write that in family members each time. So there is no family history of any swelling in the neck or thyroid malignancy or MEN-related malignancies. It becomes one sentence and that's the end of the matter. Which are those MEN-related malignancies that you took history of?
Sir, medley thyroid cancer, pheochromocytoma, and Marfanoid habitus and neuromas. That's all.
Tell us about MEN1, 2A, 2B.
MEN1 is parathyroid, neoplasm, pituitary, and pancreatic neuron.
Somebody is writing on the screen. Please stop writing. You can write in the chat box if you want to write something. So I'm able to see it on the screen. Don't do any writing on your iPad or whatever. Yes? Carry on.
Yes, sir. Parathyroid, pituitary, and pancreatic neuroendocrine tumor. MEN2A is medullary thyroid cancer and pheochromocytoma, and MEN2B is medullary thyroid cancer, pheochromocytoma, Marfanoid habitus, and neuromas, ganglion neuromas, and that's all.
Anyway, I'll not spend time here because others would be also presenting. So do some reading about it. Okay,
Yes.
and you don't take just the history of thyroid malignancies. Now let's move to the next slide. Somebody is writing on the screen or it is appearing here, I don't know. I hope it is not on your screen.
So it's on my screen also. I mean,
don't write on the screen, no? When you're writing, it is coming out there, no? Okay. There's nothing like a historical summary.
okay. All right, sir. I'll summarize in the end. Okay.
So this is a summary of the history.
History.
Correct? Now let's move to
Examination.
your examination.
I'm not able to. Okay. Yeah.
Yes, you can see it now.
Yeah. Yes, sir. The patient.
First of all, Ekansh, I have a suggestion for you.
Right, sir.
Since you always are very keen on presenting right from the days of scope, make it a point that you present regularly in Gurukkul so that your presentation gets normal. I'm just being very blunt.
Right.
You're a good student who has no reason not to be doing well. But I think there is a problem, so you can see that here. And
Yes,
the
sir.
problem is not with anything else, but understanding what is actually expected of you. So just keep doing it. Don't hold back just because so many mistakes were picked up. Okay? So
Right.
learn from it. That's more important. So
Right.
at no point of time, it's for the others also, I'm saying that the mistakes are picked up to improve people. That's it. Let's move.
Right. Right. Thank you, sir. So the patient was examined in a well-lit room after due consent in the presence of a female chaperone, with me sitting in front of the patient and standing while I was standing behind the patient while I was palpating the swelling. The patient was afebrile. She was conscious, cooperative, oriented to time, place, and person. Performance status: she was ECOG 1. The pulse was 94, regular in rhythm, normal in volume, character. and the blood pressure was 136 by 82 measured in supine position. She was maintaining a saturation of 98% with this on room air with a respiratory rate of 16. And there was mild pallor, but no icterus, cyanosis, clubbing. There was no generalized lymphadenopathy. Nutritionally, she was preserved, and hydration status was fair. Um, Next, her BMI was 25.73. There was no tremors on outstretched hand. And after due COVID-19 protections, I checked for tongue twitching. There was no tongue twitching. Hands were not moist, also no drying of skin. No pre-tibial myxedema, and the ankle reflexes were normal. Then I checked for eye signs. I'm sorry, I could not cover the patient's eyes. I should have covered. I had to demonstrate the eye signs. So the all the eye signs were negative. It's the same video of the same thing. Okay. The on inspection of the regional inspect examination, the trail sign was negative. There was mild fullness in the lower aspect of the anterior neck, close to the midline, just to the right of it. I could not observe a definite swelling there. No, there was dilation of veins observed over the chest. There were no scars, no sinuses, fistulae, no skin changes, and I could not appreciate any movement of any swelling over on deglutition. And there's another photograph here demonstrating that there's mild fullness in the lower aspect of the anterior neck with no definite swelling observable. On palpation, however, I could palpate a swelling in the neck in the anterior aspect, just right of the midline, which measured 2.25 by 2.75. It was 1.5 centimeter from the suprasternal notch, 3 centimeter from the second neck crease, and 2.5 centimeter from the anterior border of the right sternocleidomastoid. There was no local rise of temperature over the swelling. Uh, it was non-tender, and it was smooth surface, hard in consistency. It moved with deglutition, and the lower margin could be appreciated more so on deglutition. This is the video of this suggesting the same. Moving ahead, I confirmed since it was small swelling with the Kyle's method. I confirmed the movement of the swelling with the deglutition. The swelling was also mobile on the underlying trachea with the skin pinchable over it, and no thrill was felt. On palpation, I confirmed that the trachea was central. Bilateral carotid pulsations were well felt. There was one lymph node that I could feel on the left side of the neck, which was hard and tender. It was about 1.5 to 2 centimeter. And another lymph node I could feel on the right side of the neck, which was soft, non-tender. And on auscultation, there was no audible bruit. This is the video of the same which we have covered. Moving on, respiratory evaluation was within normal limits, so was the per-abdominal evaluation. Cervical spine, I'm sorry. I'm sorry. Cervical spine examination was normal, and overall, there was no point of tenderness over the spine. The long bones, there was no site of tenderness, no long bone deformity. The central nervous examination and a CVS examination was within normal limits, and PV examination was not done. Uh, Hence, my case is a 33-year-old lady hailing from Delhi who complained of hoarseness of voice for the last 4 years and swelling in the anterior neck, difficulty during speech and shortness of breath on exertion for 2 years, and weight loss of 15 kgs over this same time duration. with features of hypothyroidism, no features of hyperthyroidism, and no compressive features. Uh, the same was confirmed on examination with the right solitary thyroid nodule of size 2.25 by 2.75 centimeter, which the patient is clinically hypothyroid with no compressive or infiltrative features due to the swelling, or no features of metastatic disease with cervical lymphadenopathy. Impression probably malignant etiology. Thank you.
Uh, this patient you described, looking at your summary.
Yes, sir.
Hmm. No compressive and infiltrative features, but clinically hypothyroid. That's what you're saying, no?
Yes, sir. Right.
So she has actually gained weight and she has features of hypothyroidism with no compressive or infiltrative features due to. You'll have to give me a diagnosis, no? This is you found out your own way of describing things. My case is a 33-year lady hailing from Delhi, complained of hoarseness. There are 5 lines in everything. Well, reading it also is a big effort. I'm trying to keep my focus. For the last 4 years, swelling. Why are you making anything look so big? There is a hoarseness. Patient has features of hypothyroidism for the last 4 years and a swelling in the thyroid. There is a thyroid swelling. Why are we talking about anterior neck, anterior neck? Isn't it a thyroid swelling?
Yes, sir. Yes, sir.
So why I mean now this summary is looking like your history again. So the patient has a thyroid swelling with features of hypothyroidism and a lymph node palpable in the at what level of the neck? You said left side, but that makes no sense to me. What level?
To level 2B, sir.
So level 2B you can't say here. Level 2, that's it.
Yeah.
So give me a diagnosis which makes sense. You don't keep on repeating the same thing. Why do I need to know about weight loss? You've written weight loss here, 15 kg.
Sir, I intended to, I minimized it. I mean, I intended to remove it. I just kept the lower part as the,
No, no, I am asking you. Don't tell me a long story again. You're very fond of telling stories. Weight gain, no?
oh, I'm sorry. Yes, sir. Weight gain. Yes, sir.
So that's all I'm asking. Don't have to give me a long story. So it's a 30,000, and there's nothing like my case. It's a 33-year lady with a hostess with a thyroid swelling, along with hostess of voice and features of hypothyroidism for the last 3 years. That's it.
Yes, sir. That's it.
Wasting time and giving a diagnosis. A 33-year lady with solitary thyroid nodule on the right side, clinically hypothyroid, probably malignant, with no compressive or infiltrative features. That's it.
Yes, sir. Right.
Where is the question of mentioning the metastatic disease here again? I think you're very fond of giving a history like or features like physicians. They take. I have nothing to take away from them, but there's a lot that they write to them. We as surgeons like to be focused on what we are saying. So can you repeat the diagnosis I've just told you? Till the time you don't repeat it, I'll keep on asking you.
Okay. Hence described is a 33
No,
year.
hence described is cut. There's nothing like hence described. Give me a provisional diagnosis. 33-year lady with right sided solitary thyroid nodule. I don't want size here. Clinically hypothyroid, probably malignant, with no compressive or infiltrative features. That's it.
Yes, sir.
Now, the cervical lymphadenopathy is a part of malignant features. That's why, I mean, we've taken a lot of time with your case. That's why I wanted to cut it short. Next slide.
Sir, so that's all. That's all.
So you should have given a proper diagnosis now. That's what is the case, and I'm sure we can discuss it at length. Even your physical signs, they were too detailed for comfort, especially when they are negative. I mean, you would take test for signs of toxicity because we can find out whether the patient has got toxicity or not. Here is a patient who is hypothyroid. Now, I would want everybody to now focus on these slides. I'll try to write and maybe keep on asking you also, and you can meanwhile ask questions. He has made his presentation. Questions can be asked by all of you. Right, you can all write your questions if you want, because I think there'll be many. And we will take them one by one. Now, is the slide visible to you? Can you see what I'm writing? Ekansh?
Yes, sir. Yes, sir. I can see what you're writing, sir.
Okay, good. So I'll be able to summarize. That's why I was. See, we have a 35-year lady with a solitary thyroid nodule, right side, with hypothyroidism and features of malignancy. That's why you are constantly answering the reason for hoarseness to be only recurrent angular involvement. And I was asking in connection with hypothyroidism. You know that in hypothyroidism, they have a bloating of voice, or they have a voice disturbance due to hypothyroidism, deposition of mucopolysaccharides on the tongue. The tongue also becomes bigger and down to larynx, and the movement of the muscles becomes sluggish. That's why they continue to have, they have jaw pains, etc. Now, 35 year, I won't ask you. You spent a lot of time describing the, the aspects which were not even necessary for us. Now, what is the solitary thyroid nodule, Ekansh?
So, solitary thyroid nodule is a discrete swelling in the thyroid gland with the rest of the gland impalpable.
Okay, you will take time. So it is a nodule palpable, only nodule palpable, in an otherwise impalpable gland. Because any gland which is palpable is enlarged. So that's as simple. So we are looking at a swelling which is a nodule which is the only nodule. So that's one thing about solitary thyroid. She's on the younger side, 35. Now the features of hypothyroidism here are few features are present. Weight gain, sluggishness, and what else?
Constipation, sir.
Constipation, and something to do with the menstrual
All
disturbance.
yes, sir.
These are the points which go in favor of hypothyroidism. Now, what are the features of malignancy here? One you mentioned, in the history there's nothing.
So
Except hoarseness of voice.
So there are historical features and examination features. On history, there's hoarseness.
There are no historical features. I'm telling you, you're using the word wrongly. There's a features in history.
All right, sir.
Historical features would be somewhere in 1857 that something happened. Okay, don't try to use the word wrongly.
All right, sir.
Okay, so there are features, there are points in history and points on examination. That's what you're saying?
Yeah, right, sir. Right, sir.
And what are the points that you were talking about?
Yes, sir. Points in history in favor of malignancy are hoarseness of voice and compressive symptoms. And points in examination are.
No, which compressive? She has no compressive symptoms.
She has exertional shortness of breath.
You said there are no compressive symptoms in your brief history. You did not. And shortness of breath is a compressive symptom.
So it could be compressive, or it could.
How? Tell me, what are the causes of shortness of breath?
So it is more likely because of hypothyroidism in this case. Yes.
Therefore, don't try to unnecessarily add things. There is no compression. There is hardly any swelling to compress. At one point, you're saying swelling is not even visible. And at the other point, you're saying it is compressing. It's like you're getting crushed under the weight of a mosquito. Is it likely?
Right.
So, there are no compressive features. Don't add stories. You're very, very fond of stories. Now, so this is out. We are back to the features on examination. There is a heart swelling. I am finishing it because it will take a lot of time. And there is a lymph node. Right.
Right.
So this is a case of they add up to the features of malignancy. Now, what was the significance of testing for eye signs here? What are the eye signs for?
They are for thyrotoxicosis.
What does your patient have?
Hypothyroidism.
So you should be clear on that. So you could have ended up by simply saying no eye signs as expected, suggestive of any toxicity, rather than wasting a lot of time. Which specific features on examination support the diagnosis of hypothyroidism? First on general examination, then on any specific examination. Please answer that question. It's a basic MBBS question. And don't try to read it in the book. You won't get it.
Sir, she has she's overweight and she
No,
has.
that's done. That's in history. I'm saying in examination. Have you heard of some edema somewhere which is non-fitting? Pre-tibial mixed edema. Sir, you should do some reading. You have a problem. You don't read. I don't know. You're not presenting. You're everywhere. Presenting in scope, presenting in Gurukkul, but then unless you make an understanding, it is going to be a problem. And you would look for, that's in hyperthyroidism mostly. What do you see in hypothyroidism? You may find puffiness around the eyes, right? The eyelids swell up. Same reason, there's a deposition. And actually, they have eyes which are hardly opening up. In fact, while you're talking to the patient, he may fall off to sleep. This is the kind of lethargy they carry. Okay. Now, your diagnosis is, I'm repeating, a 35-year lady with a solitary thyroid nodule on the right side, which is clinically euthyroid or hypothyroid, sorry, probably malignant, with no compressive features. How do you proceed now? Quickly, we have 5 to 6 minutes to finish your case so that we can move the other case too. What do you do now?
Sir, I evaluate the patient with a triple test with a thorough history and physical examination as we have done, followed by thyroid function test and imaging, which preferably a high resolution ultrasound with Doppler, and followed by an ultrasound guided fine needle aspiration cytology.
But that's not correct. Not the way we teach every time. So investigations to confirm my diagnosis, confirm the diagnosis. So to confirm support and for treatment of the patient. To confirm you're right, you do a triple test, which is your right history, including family history, followed by imaging, which is high resolution ultrasound and also elastography. To that you can add Doppler, you're right. Followed by thyroid function tests, followed by FNAC. Why thyroid function test is mandatory before FNAC?
So firstly, because because if the patient is hyperthyroid, then we might precipitate a thyroid storm. Secondly, it is not needed. There's just 8 to 10% cases in which it is malignant, and third, it gives high false positivity rate.
So we have to therefore avoid it. Therefore, we need to do the TFT, and that too. You're right in what you answered. And basically to prevent false positives and to prevent thyroid storm. You're right. And you may not gain much, as you said, correct? But here it's relevant because it's a hypothyroid case with feature suspicious. So you are saying image guided FNAC, which I accept as a correct answer. So you'll do that, and the management would be depending upon what finding you get on FNAC. Can you tell us the thyroid scoring with ultrasound?
Yes, sir. Thyroid scoring has 5 components: composition, ecogenicity, shape, margins, and ecogenic foci. Composition, the uh, the cystic or almost completely cystic or spongiform are scored 0. Solid, partially cystic is given 1. Solid is given 2. On ecogenicity, hypoechoic is given 2. Isoechoic is
All
given
right.
1.
And what about
Hypoechoic
the
is given 2.
FNAC staging? What are the methods of FNAC staging? What methods are adopted for FNAC?
For FNAC staging, sir, I know of Bethesda staging and Thai staging, sir.
Very good. So tell us about any of those.
On Bethesda staging, we have Bethesda 1 is non-diagnostic, non-satisfactory. Bethesda 2 is benign. Bethesda 3 is ATP of undetermined significance, or a follicular lesion of undetermined significance. From Bethesda 4 is a follicular neoplasm or suggestive of suspicion of follicular neoplasm. Bethesda 5 is suspicious for malignancy. Bethesda 6 is malignant.
Good, Ekansh. Have you read about the TNM staging for thyroid malignancies now?
Yes, sir, I've read about it. So the
Can you tell
TNM,
us?
yes, sir, the TNM staging, it divides on the age cutoff of 55 years. So less than 55 years, any T, any N with M0 is stage 1. If there is M1, it becomes stage 2. More than 55 years, if more than 55 years, if there's distant mets and it is a differentiated thyroid cancer, it becomes 4B. And if it's T4B, that means pre-vertebral fascia involvement, carotid involvement, or upper mediastinal vessel involvement, it becomes 4A. If it's
Rest. You're absolutely right. The cutoff is moved from 45 to 55 now, and it has got to do with the possibilities of malignancy and the occurrence of the age-related risk. Very nice. Now, suppose on FNAC it comes out to be a papillary variant, follicular variant of papillary carcinoma with a node which is positive. What do you do for the node? Clinically, there is a node also, and ultrasound also shows node. So, what features on ultrasound would indicate that this is a metastatic node, and what features on ultrasound would indicate that it's a malignancy?
So, features of the swelling that would indicate malignancy on ultrasound is hypoechoic, hypoechoic swelling taller than wide, with the lobulated or irregular margins, extrathyroidal extension, increased vascularity, a resistance index, if Doppler is available, resistance index less than 0.7, and finally peripheral or rim calcifications or punctate ecogenic foci. Of a node, it would be around a spheroidal shape, an absence of fatty hilum or effacement of the hilum, a non-cortical blood flow, an eccentric cortical thickening more than 3 mm, and finally
Not bad.
microcalcifications.
So, basically, we are looking at You know, this is a right-sided solitary thyroid nodule, is it or not?
Right, sir.
Yes or not?
Yes, sir. Yes, sir. Yes, sir.
So when you were staging it in your TNM with the node, now what would be your clinical stage? This patient, considering your T size, N status.
Sir, I would see it as T, T2N1B M0 because it's the lateral compartment.
I agree. And what is N2?
There is no N2, sir.
So is that clear now? That is why somebody had written that, so they should not do that mistake. The other thing is, you've got the nodule on the right side and a lymph node on the left side, or they're on the same side?
So both are on. There's one lymph node on the right side, one on the left side, but the ipsilateral node is the one which is hard.
Okay, so that is on the right side. Am I right?
Right, sir.
Okay, so we'll draw it accordingly. We have a node. This is the gland nodule, and that's the node now. And how do you confirm your diagnosis of the node? We've done a high resolution ultrasound. And when you do high resolution ultrasound, generally speaking, it is similar as you have in breast. Taller than wide lesions, hypovascular, hypoechoic areas of necrosis inside, loss of halo if it is extracapsular spread,
Yes, sir.
joining structure involvement. And for the lymph node, it will be again spheroidal with central hypoechoic region and loss of fatty halo, which you mentioned. That's fair enough. And we move on to the management with this status. What is the likely clinical type?
So likely clinically papillary thyroid carcinoma.
Why do you say that? You're right, but I want to know.
So because there is lymphatic spread, and secondly, it is the most common type.
Yeah, first of all, it's a lady, which is where it's more common. And this is indeed the commonest type. So we are looking at
Papillary thyroid.
most probably papillary. And why do you think this patient has hypothyroid? What is the usual reason? They can be hypothyroid, you agree, no? Or they can be euthyroid. Only 5 to 7% are hyperthyroid. So most of them don't secrete. What could be the other reasons? And she has features of hypothyroidism, which are quite striking. Can you give some explanation?
Sir, they could be the swelling could be compromising the vascularity of the normally functioning follicular thyroid follicles.
See, when you don't know, say you don't know, rather than giving all garbage. That doesn't help. You don't know, say you don't know. Why are you guessing?
Sorry, sir. Yes, I don't know, sir.
Yeah, the malignancy infiltrates into the gland. There's no secreting tumor. But I was asking a different question. Here is a patient who's got a background of a swelling appearing in the hypothyroidism. Many a time there is a patient with lymphocytic thyroiditis, right? Lymphocytic thyroiditis, which leads to thyroidism. You know that because the nodule, the thyroid is all eaten up with the autoimmune phenomenon. And in that, you have these malignancies lurking up. Therefore, papillary happens there. That's one reason. It's not such a large tumor that it will stop even the left side from functioning. Getting my point?
Yes.
So the other reason in malignancy why it becomes a cold nodule is because the malignancy eats up all the secreting follicles. So this is how we explain it. But very commonly in the setting of thyroiditis, there can be malignancies. And they may have more pronounced hypothyroidism compared to the normal gland developing malignancy. Okay.
All
now,
right.
this is your case. Suppose your case is a papillary, as you're saying.
Yes.
What
sir.
is the significance of doing FNAC from the node, or we don't do it from node at all?
No, sir. We should do an ultrasound guided FNAC from the swelling and from the node both to know uh, um, to know whether the node has metastasis from the thyroid swelling or.
Well, so you're struggling to answer that. You can be more clear. We can do FNAC from the node. If the features are suggestive, it's recommended now. There's no shame in it. And you need to be very sure because the plan would change. Now, this is your case. I've drawn the picture. What would be the approach? What would you do to manage it?
Sir, after the triple assessment.
So I told you about the investigations to confirm the diagnosis. We've done that. To support the diagnosis, any imaging more than this that you need to do, I don't think we require. You don't need a CT here. What are the indications for CT scan in a thyroid malignancy? Retrosternal extension or 4B, which you mentioned, where the involvement of carotid sheath, skull base, etc., extensive disease, recurrent laryngeal nerve involvement. That's what they say. Now, so you'd like to do indirect laryngoscopy to see the functioning of the laryngeal, the vocal cords.
Indirect
and also
laryngoscopy
the,
and voice assessment.
Voice assessment, questionnaire-based assessment, and voice assessment is mandatory.
Yes,
She already has a bad voice. Okay.
Yes,
and
sir.
based on that, you will plan your treatment. Suppose the recurrent laryngeal nerve is not involved, and she's just not able to sing in the bathroom now because of being too lazy. That can happen.
Yes, sir.
And somebody raised a question about Hashimoto's. See, the gland becomes hard. Once it becomes hard, the granulomatous feeling is gone. It is granular when there is no malignancy. With malignancy coming, the consistency will change. It's not, then it becomes, sometimes you cannot feel the gland. It becomes kind of a hard thing only. That was the answer. Somebody had asked a question. Anyway, so what would be the treatment in this case?
All right, sir. In addition, after the voice assessment, we could go ahead with the BRAF mutation testing because it responds badly to radioactive.
BRAF mutation is not available everywhere, so you're talking about quadruple test. BRAF mutation can be done in a high-risk case. To how does it help you? One is, yes, it allows you to know whether the patient would respond to radioactive iodine or not. But how does that help you? Suppose you find out it is positive. It gives you a reason to do central neck dissection even if the nodes are not involved. Some people like to do a central neck dissection in these cases because they think this patient will never respond to any radioactive iodine later on. So might as well do surgically as aggressive therapy as possible so that we don't have to depend on adjuvant radioactive iodine therapy. So that has been done. What surgery would you offer? Total thyroidectomy with bilateral neck dissection if they are both positive. Otherwise, one side. What neck dissection? Usually it's MRND, dye, green. Try to preserve. And a lot of people feel you can do selective neck dissection because level 1 is rarely involved. So you can spare level 1 and be done with it. Okay. So that's the case. And then the steps of surgery, etc., would come. We've discussed thyroid many times. You must go back to our YouTube videos. You have seen them all and revisit the history taking an examination. Because the part which was related to the theory of treating, you were able to answer most of the questions. Suppose the recurrent laryngeal nerve is involved, then what do you do?
Sir, if we can, so it has to be repaired, sir. I mean, we excise the entire tumor and the recurrent laryngeal nerve has to be repaired with.
Can you hear me now?
Yes, sir. Now I can hear you.
I know there's some problem with the iPad. I touched something. Yes. So what was I asking you last question? I forgot.
Sir, what do we do if the recurrent laryngeal nerve is involved?
Yes, quickly.
So we excise the tumor in toto, and we excise that, resect that part of the recurrent laryngeal nerve, and then we repair it suitably. Yes, I don't know, but I've not read
Don't
that.
know. They don't know. I'll tell you quickly. It's the right side that we're looking at. Remember, functioning recurrent laryngeal nerve is never sacrificed. So don't just jump on it. Without sacrifice. Sometimes you can achieve clearance and you can free it. But if it is involved, functioning recurrent laryngeal nerve, we don't sacrifice. On the right side, it comes at an angle. And if you can sight it, you can preserve it. But you can also resect and reconstruct using any cable, or you can use nerves which are in the neighborhood, including ansa cervicalis, which is going to the strap muscles, or you can use greater auricular also, some people have used. But that's only when you are very sure that the nerve is not functioning at all. Because in this case, you'll have to establish that first. I hope that is clear. And that should be this case. The questions I'll take at the end so we can move to the next case. Otherwise, we won't be able to finish. Right, Ekansh? Well done. And stay alert to the questions as we'll ask as we move to the next case. Okay?
Thank you, sir. Thank you for your time, sir.
You're welcome. And don't take what I spoke in a manner which won't help. You should be looking at making it better each time. And I'm sure you're capable of doing it. You answered beautifully all the questions that I asked you later on. So do concentrate on your history taking also. Don't make it too elaborate unnecessarily. It should focus on your important issues.
Right.
Shagun, are you able to hear me? Shagun?
Yes, sir. Audible, sir.
Yeah, share your screen now.
Yes, sir. Sir, host disabled participants screen sharing is yes, sir.
I made you the ghost now.
Yes, sir. Okay, yes, sir. I hope I'm audible and visible, sir. Hello.
You're audible.
Yes, sir. So shall I start, sir?
Yeah.
Good evening, everyone. I'm here to present a case. This patient is a 60 years gentleman who is a resident of Shadipur, Delhi.
You can switch on your video, no problem. I'm switching mine off. You can switch on.
Okay, sir. Sir, the internet goes haywire after I switch on the video.
Okay.
Yes, sir. My patient is a 60 years gentleman who is a resident of Shadipur from Delhi and is a daily wager by occupation, who presented with lump in the left lower abdomen for last 10 years and pain in the lump for last 1 week. The patient was apparently well 10 years ago when he noticed a lump in his left lower abdomen, which was initially 2 × 3 centimeters approximately in size and was painless to begin with and was non-progressive, used to increase in size upon cuffing and heavy weight lifting, and used to reduce spontaneously upon lying down and on manual manipulation. There is a history of acute onset pain in the lump for last 1 week. The pain is stabbing in nature and is non-radiating, and there are no aggravating or relieving factors, and the lump has now become irreducible for last 1 week. The lump has also increased in size to approx 10 × 8 centimeters progressively over the last 1 week. There is no history of fever, vomiting, bowel or bladder complaints, and overlying skin changes. There is a history of chronic cough present, which is dry and is present on and off. There are no known comorbidities. There is a past history of stab injury about 20 years back in the left lower abdomen, for which the patient underwent primary closure of the wound, the documents of which are not available with the patient. There is no past history of any surgery. and there is no past history of tuberculosis or contact. The patient has normal bowel and bladder movements as mentioned earlier. He has a normal sleep-wake cycle. He is a known alcohol consumer and a daily BD smoker for last 20 years. Shall I move on to examination, sir?
That's about your history.
Yes, sir.
What impression do you make based on your history?
Sir, this seems to be a case of sir, hernia, which was reducible initially and now has become irreducible with no feature suggestive of obstruction or strangulation, sir. Based on
come back to your first slide there.
yes, sir.
Is that a lump or is it swelling?
Sir, lump, sir.
So basically, you are aware that it's a hernia.
Yes, sir.
Clear?
Yes, sir. Yes, sir.
And you don't make a story out of it.
Yes, sir.
So if I were you,
yes, sir,
and I was appearing in the exam, my answer would be simple. My
yes,
description would be straightforward. The patient complains of a reducible swelling in the left lower abdomen for the last 10 years
yes, sir.
and pain in that swelling for the last 1 week. That's it.
Yes, sir.
Now, the moment I say reducible swelling, I'm giving an impression of a hernia.
Yes, sir.
Lump is very commonly used for swellings which are usually persistent. They don't disappear. I'm
Okay.
not saying there is any rocket science. I mean, there is no, it's not that you cannot do the way you've done it,
Yes, sir.
but I would not call it a lump. I
Yes.
would call it a swelling.
Okay, sir.
But I would call it a reducible swelling to look comfortable.
Yes, sir.
Next slide. Now again, so now it becomes, I mean, you can easily make out there is a swelling, the history of present illness says, swelling in the left lower abdomen.
Yes, sir.
That was noticed 10 years ago, which is approximately 2 to 3 centimeter, non-progressive, etc., and would reduce spontaneously. Already written there.
Yes, sir.
For the last 1 week, there's been acute onset pain, which is described properly. The swelling is increased now to this size, and it's no longer getting reduced. That's what you told me. I mean,
Yes.
that's why I understand. The story should be over here. So you basically are talking about a hernia, which
Yes,
is now, which was reducible, has become irreducible now. So
Yes,
then you don't get into the controversy of, lump or a swelling.
Yes, sir.
Okay. Although technically lumps are better, palpated swellings are better seen.
Yes, sir.
So you see the lumps. Lump can be deep-seated, right? So you don't talk about, liver, which is on the posterior surface, as a swelling because you can't really see it.
Yes,
So that's
sir.
called a lump usually. So that's conventional. You
Yes,
understand
sir.
what I'm saying?
Yes,
It's
sir.
a very
Yes.
clear seeing swelling which is reducible. And now for the last 1 week, it has become irreducible and painful. That's your entire story. You mentioned about no history of fever, vomiting, everything else is fine. Okay? Because
Yes.
that lump itself is giving that kind of an impression.
Okay, sir.
With the rest, I'm fine.
Yes, sir.
Let's go to the examination.
I examined my patient in a well-lit room after taking informed consent. My patient is conscious, well-oriented to time, place, and person, has a normal intellect. My patient was examined in supine position with arms by the side and adequate exposure. The patient looks dehydrated on account of mucous membrane status. His pulse rate is about 98 per minute, which is regular and low volume, has normal character and no radiofemoral delay. His blood pressure is 150 by 90 millimeters of mercury in the left arm in supine position. He is obese on account of BMI, which is 31 kilograms per meter square. The rest of the general physical examination is within normal limits. This is the swelling. On abdominal examination, the abdomen looks mildly distended. Umbilicus is centrally placed and inverted. There is a scar of approx 3 into 1 centimeter size present in the left iliac fossa region, overlying a swelling of size 8 into 10 centimeters, which is globular in shape, extending into the left lumbar region with no overlying skin changes, and extensile cuff impulse is absent. There are no sinus, fistula, or dilated veins. Upon palpation, there is a lump of size approximately 8 into 10 centimeters in the left iliac fossa extending up to the left lumbar region with no local rise of temperature. The lump is non-tender, soft to firm in consistency with well-defined borders, has smooth surface, and is non-reducible. Rest of the abdomen is soft, non-tender with no guarding or rigidity and no free fluid and no organomegaly. Upon percussion, there is a dull node present over the swelling and tympanic node or node over rest of the abdomen. Upon auscultation, bowel sounds are present and are normal in frequency and intensity. Upon digital tactile examination, the anal tone is normal with a collapsed lumen and presence of fecal stain. The genital examination is unremarkable and spinal examination is also within normal limit. So my diagnosis, 60 years gentleman with a non-reducible swelling in the left iliac fossa with no feature suggestive of obstruction or strangulation, most probably an irreducible incisional hernia.
That takes care of it, right? Now it's falling into place when you call it a swelling in history and lump on examination. But actually, for examination also, can you go back on your first slide quickly? Not the general examination, abdomen.
Yes.
Now don't have to say extensile cuff impulse absent.
There is no cuff extensile.
That's right. So you know it.
Yes, sir.
And it's not an attendance sheet that you're filling, right?
Yes, sir. Yes, sir.
Rest is fine. Next slide. You mentioned about 8 into 10 centimeter. What is important here is that lump parietal or intra-abdominal?
Parietal, sir.
If it was parietal, now it looks like parietal. You see, there is no parietal in incisional hernias. The wall is already broken.
Broken, yeah.
So you can't really comment on it. This is a common mistake that people make. So it's both intra-abdominal and also parietal. That's how it is a hernia.
Yes, sir.
Part of it, it's like you are standing inside the river, right? And if you're asked a question, are you inside the river or outside? You will say, I'm inside as well as outside, because unless you drown, there is a part of you which is up above the surface of the water.
Yes, sir.
It's exactly the same. So part of a hernia is intra-abdominal, part of it is parietal.
Yes, sir.
So when you reduce it, it will become all intra-abdominal.
Yes.
And when you allow the patient to cough, it is parietal, but then there is a part which is deep to the parietal.
Yes, sir.
So in a hernia, it's not possible to comment whether it is intra-abdominal completely or parietal completely. Are you getting my point? It's
yes,
important.
sir.
So the moment you say cuff impulse was present and it is absent now, we don't know it. But it is certainly presently a parietal swelling for you. You don't know the deeper limit. Only your diagnosis makes you suspect it. Okay. Next.
Yes,
dull node over the swelling, tympanic node over the rest of the abdomen. When do you call it dull?
Sir, when
the rest of the abdomen is tympanic, sir.
No, sir.
If the rest of the abdomen was also dull, it will be the same as the abdomen. You don't have to highlight the second part.
Yes, sir.
Because the whole abdomen cannot be tympanic also.
Okay, sir.
Abdomen has quadrant in the legs, where you find, don't have to write this, no? You're doing more or less a few things that they can't get. I think these things always need correction. So there is a dull node over the swelling. That's it.
Yes,
the rest I'm not interested in.
Yes,
Next. Now the rest was fine. PR exam. Bowel sounds present, you've written. Am I right?
Yes, sir.
Yeah, he's a living person. He's got bowel. So they will be sound. They are not exaggerated or they are normal. That's the way you write. Present is no statement. What is the significance of bowel sounds in this patient? If there is obstruction, they will be exaggerated. If there is perforation, they will be sluggish. Right? So
Yes,
what
sir.
do you say in this case? Normal. I'm trying to correct the way you people present. Now
Yes,
coming to DRE, normal ileal tone, rest of the examination is normal. Don't try to say fecal stain present, which you're trying to say mainly because you're saying no obstruction. Okay. So if you say normal, that takes care of it. There's nothing absurd, nothing completely wrong here. I was just trying to make it better.
Yes.
You gave me a diagnosis now. Let's come to the diagnosis. I think a diagnosis is absolutely correct. I don't have to add anything here. And now you can stop sharing screen so that I can use my slides and you can.
Yes, sir.
So, do you have a differential?
Sir, we can, sir, although there is a history of stab injury, so still we can keep Spigelian hernia in the differential, sir.
That will still be a hernia, no?
Hernia, yes, sir.
First, I'm talking about it being a hernia. Let's forget about the type.
Yes,
It's a
sir.
hernia, not a parietal swelling.
Yes, sir. Hernia, sir.
So, what is the differential diagnosis in this region if it was not reducible? And it's a parietal swelling.
So, desmoid, sir.
Okay, one.
Otherwise,
any swelling arising from the parietal. It can be muscle, it can be fat, it can be nerves, and it can be all of them together. So what will that do? That will make it into a swelling which is parietal and non-reducible. I'm not talking about this case. Generally, you should know.
Yes,
I'm trying to extrapolate so that I can use it for
Yes, sir.
teaching. Now, since you could not reduce it,
so the audio is gone, sir. Sir, not audible, sir.
can you make me the host now?
Yes, sir. Yes, sir. You're
No,
audible.
then you ran away.
Yes, sir. You're audible now, sir.
Yeah, so I'm just trying to get the screen also so that I can.
Yes, sir.
I can tell you. So how do you proceed?
Sir, so since this patient had a low volume pulse with the tachycardia, we first established IV line and resuscitate the patient. We put in a Foley's catheter and look for urine output.
Didn't get the question. Unless the Foley's catheter is for finding out the urine output only. You can't do CVP assessment there. You don't have to unnecessarily talk. We put in a Foley's catheter to find out the urine output. Obviously, what else will you find out through the Foley's?
Yes, sir.
What will come out of the Foley's?
Urine only, sir.
Don't try to unnecessarily talk and talk and talk. You will be sometimes careful. If the person who's talking to you is intelligent, you're in trouble.
Yes, sir.
I'll put in a Foley so that I can see there is urine, and then I count the amount of urine, and then I'll see how frequently the urine is coming out. So rubbish. This is the case. Have you made your diagnosis?
Yes, sir.
What? No, that's your clinical diagnosis. So I'll have to confirm it, no?
Yes, sir.
You may be making a big deal about nothing. Patient has no features of obstruction. Does the patient have features of obstruction?
No, sir. No features of
Why are you
obstruction.
putting in a Foley's catheter? It's an irreducible, but not an obstructed hernia. Is it obstructed?
Yes, sir. No, sir. It's not, sir.
So I hope you're not doing it. As soon as the patient comes, you're putting in a Foley's, and then let's find out whether it got some problem or not. What is this Foley's here for?
Yes, sir.
What is Foley's going to do here?
It can decompress the bladder and also.
No, don't be ridiculous now, Shagun. Your patient is
Yes.
the patient in shock?
No, sir, he's not in shock, sir.
So let's confirm the diagnosis. What will you do? You're wasting time.
So I would go with the ultrasonography of the whole abdomen as an
Okay, you've
extension
done
of
an ultrasound. What do you want to see on ultrasound?
so of the viability of the contents of the hernia, sir.
No, first you confirm it's a hernia.
The hernia, yes, sir.
And then you want to see the size of the defect.
Size of the yes, sir.
And you have no tendon, there's no tenderness. She's got pain, he has got pain, but no tenderness, no? So there are no
Yes, sir.
features of strangulation on examination.
Strangulation.
You want to confirm
Yes,
it
sir.
on ultrasound. Any features of ischemia. Patient
Yes,
has no obstruction also.
Yes, sir.
Is there any scar there?
Yes, sir. There was a scar, sir.
What did you tell me about that scar?
So the scar was approx 3 into 1 centimeters, which had healed by primary intention, sir.
Is that enough about description of a scar?
Lying in the left iliac fossa region, overlying the swelling.
Site, size, shape, discharge, any local tenderness or hyperesthesia, cough impulse. These are things you look for.
Yes, sir.
All these should be covered. Tenderness would mean some infection,
Yes, sir.
inflammation. Hyperesthesia would be taking it towards keloid or hypertrophic scar. And cough impulse, whether there is an incisional hernia or not.
Yes, sir.
If cough impulse is absent, discharge will also indicate some infection. Sometimes you have threads coming out, sometimes you have sinuses, all that falls into the space. Then shapes, which means length as well as the width.
Yes, sir.
So all that was missing in your description of the scar. Because on the basis of a scar being there and a reducible swelling being there in the beginning, which has become irreducible, you have made the diagnosis. Ultrasound, you want to confirm what you've made as a clinical diagnosis, and then you want to approach it with that diagnosis. Any more investigations required, or you're done?
So we should get a baseline chest X-ray and X-ray abdomen supine in erect.
How old is your patient?
So 60 years male, sir.
So you need ultrasound would tell you more information besides what you just told me.
Yes, sir.
It'll tell you about the prostate, the post-void urine, any hypertrophy, hydronephrosis, etc. It'll tell you that also. For straining, you can check for it. So ultrasound will give you a lot of information. So don't jump to Foley's catheter straight away, finding out the amount of urine that the patient is passing. So don't just kill the issue. Now, what do you do in terms of, suppose your diagnosis is correct, what is the management?
It's open hernia repair, sir.
Emergency surgery or planned surgery? First question is this.
In this case, planned, sir.
How do you decide that?
Sir,
what will be the clinical features of strangulation in such patients?
The patient will be running fever and
so there'll be pain, which would show a pattern. There'll be constitutional symptoms, right?
Yes, sir.
Locally, there'll be tenderness out of proportion to pain. There'll be more tenderness than pain. Actually, strangulation leads to that. Yes. And of course, patient will have tachycardia and fever, etc. And you will do the investigation. Patient will have raised TLC counts and all those features of infection and sepsis. So that is in nutshell. I'm not trying to take your theory here. Now, if the patient is all stable and it doesn't look like a case where you are not having any acute problem, you don't need to take it up in emergency. But whenever in doubt, take it out.
Yes.
Doubt, out. In that case, you take up in emergency. And there is no difference between strangulated, irreducible hernia when it comes to planning of surgery. The answer is the same. For both, the answer is surgery. Should you try taxes?
Sir, in irreducible swellings, sir, taxes can be tried under conscious sedation, sir.
So taxes can be tried. It's the most ridiculous answer you've given ever in life. Don't ever, I'm sorry on the air I'm saying. Taxes is banned, it's obsolete. If you learned it somewhere, please don't even do it. Why is it contraindicated?
So the contents the hernia contents might be non-viable, and then they might enter when they enter the abdominal cavity.
So if you don't know, don't waste everybody's time. Let me answer that. Reduction in mass. What is reduction in mass?
I don't know, sir.
That's the problem. And you're managing hernias every day. And I only hope you have not done taxes any time. If you've done it, it's a criminal offense. And if you see anybody doing it, please convey the same to that person also. No taxes. All students should learn this. Don't even mention taxes and never do that. You can have reduction in mass, which is the whole content along with the constriction ring goes inside. And somebody has written that it's seen in strangulation. That's a wrong answer. You have reduction in mass, which happens in an irreducible hernia if you try to reduce it forcefully. Yes, you can put the patient on sedation. It may reduce on its own. You must have seen some people putting the patient in a particular position. And at least I have seen it. That's why I'm saying it. In some centers, they do that. And some students who come to join residency at our place, they come with that baggage. What do? They put the foot end up. That's a bed. That's a patient. And that's his body. And these are the limbs. Then they put something here also. They make a chopper out of the patient, hoping that it will reduce. It's the most stupid thing to do. It is not to be done. It doesn't help. He was here. Now he's here. It is likely that he'll either develop head injury, I've seen it happen because he'll slip off, or he'll have brain congestion. It's a wrong thing to do. No positioning makes a difference. Please understand. The treatment for an irreducible hernia is emergency surgery. You don't need strangulation to do that. You take it as a strangulated hernia unless proven otherwise. Treat it by doing surgery. And in emergency surgery, we don't use a mesh. So that's a disadvantage. Mesh has been shown to produce less recurrences. So therefore, it is good to operate it in a planned OT when it's not contaminated. But in a contaminated field, OT or a surgeon being contaminated, no mesh is used. So no taxes cannot be overemphasized. And the reason is reduction in mass, where the whole thing goes in. Suppose it reduces on its own. What is the protocol of management? You will still observe the patient for 24 hours because they can develop the features of obstruction. Reduction in mass can happen even on spontaneous reduction also. Be careful about this. I wanted you to understand. And I think that is where this case rests. What will be the planned surgery? Shagun, quickly. I hope you have understood now.
Yes, sir.
You said we can plan taxes under sedation. Who sedated? Patient or the doctor?
Patient, sir.
Yeah. It will be a sedated doctor who's absolutely off his rockers who will do taxes. And I've seen some people use ice packs to reduce it. It's ridiculous. Please don't let it happen when it happens. No taxes.
Yes, sir.
Clear?
Yes, sir.
The term is used when you're describing hernia examination in the reducible hernia, where you try to guide and reduce the hernia. That's a different word. In an irreducible hernia, no taxes. The answer is surgery.
Yes, sir.
Yeah?
Yes,
What do you
sir.
do in a planned surgery? Last question.
Sir,
Now,
yes. So a tension-free open mesh plastic, sir.
Yeah, and this is a rare site for hernia. And the taxis problem mostly happen with inguinal hernias. That's where you see people doing those adventures. And I have operated on, I'm telling you my own experience. I have operated on patients presenting with perforation after taxis done by somebody else a day before.
Yes.
Because you're doing a wrong thing. What is not going in should not be pushed in.
Yes.
It's a principle of surgery. I hope it's clear to everybody. So our answer should be, we can do open versus, we can talk about you are basically wanting to do and tension-free hernioplasty, which can be done open or laparoscopic. Both are options.
Yes.
Laparoscopic is a challenge with this learning curve, etc. And especially in flank hernias, they can be a bigger issue.
Yes.
For fixation of the mesh. That's why a lot of people would go for it, but don't swear by it. And you can go through the same incision which was used in the past or through a new incision. It's absolutely optional. We'll not discuss the technique here. Now, I think I'll take questions so that we can finish in time. Do you have a question now? It was nicely presented, but at the end, there was a confusion. You should be clear in your concepts.
Yes, sir.
Shagun, is it
Yes,
done
sir.
or you have any questions? I'm starting with the question. Do you have any question pertaining to this case?
Sir, suppose this case was taken up for emergency surgery, and the everything, like there was just the contents were there was what do you call it? There was adhesions between the contents and the sheath, sir.
Hmm.
And no contamination was there. So could we use mesh in that scenario, sir?
You're saying no contamination.
Yes, sir.
Right?
Yes, sir.
And where are you operating this patient?
Emergency OT only, sir.
Emergency OT. What are the other surgeries you're doing in this emergency OT?
Yes, sir. So perforation and amputation.
Perforation, amputation, debridements, right?
Yes, sir.
Remember one dictum which I'm teaching you as my student. We need a clean OT, clean operative field, clean local site, and most importantly, a clean surgeon.
Yes.
Can you ensure this to me?
Yes.
How? In emergency OT, how will you ensure this?
No, sir. In emergency OT, it's not possible, sir.
Clean OT, not likely. Not likely. This you are hoping, and even this person is doing all sorts of surgeries today.
Yes,
So
sir.
not to be done.
Yes, sir.
Clear now? I'm giving you a reason. Now, there are some hospitals where the main OT is used for emergency surgeries also because they don't have emergency cases.
Yes, sir.
In that case, their OT is as good as a clean OT. So don't get into that argument.
Yes, sir.
The answer is simple. Clean OT, clean operative field, local site is clean, and I don't have any problem with the surgeon who is not contaminated because he has not done the other surgeries. Therefore, in emergency, we don't use the mesh.
Yes,
I hope that answers it. Any
Yes,
other
sir.
questions?
And so we use the far near far technique in this case then, sir.
That's one technique which you must have seen from me, modified Smith-Jones technique, and the one that we have modified, where we take the far, near, far. It's on YouTube. My video is there. So others can also watch it, and that's okay. Can be done. Or you can do shoelace. You can do the release, or you can do the the flank release and closer. Don't try to do component separation. In emergency, do whatever is little that you can do. Save the patient's life so that you can live to fight another day. The recurrence would happen later. You may kill him before that. Clear?
Yes, sir.
Never mind. Well done. And important thing is you present it. A lot of people are just watching others do mistakes. I'm just taking the questions now. And let me know when the slide is not visible. Shivam, should DRE be done routinely in hernia or other parietal swelling? No, not really. But DRE helps you in patients who have got urinary symptoms or symptoms of straining. Like Shagun described, the patient is like he described that sphincter is normal, the tone. So it's not direct, it's not indicated in a 30-year-old person, but in a 60-year-old it may be. So that's a subjective thing. Nobody allows you to do DRE anyway in the exam, but you can show your intent in those cases. Chetan Nittal, sir, I could not get what is reduction in mass and the reason why TEXI should never be attempted. Okay, I'll tell you again, pay attention. This is the inguinal hernia. I'm not going anywhere. Somebody asked for the inguinal hernia. That's a ring and the neck where there is obstruction. And the sac is, this is the sac. Let me use another color. And you know the approach, we go through the inguinal scrotal incision because we don't want the contaminated part. So incision therefore extends lower down. And this is the only time when we open up the sac to drain out all the dirt that is here. So what is looking green is all contaminated fluid which is teeming with bacteria. So you drain it out, check for the viability and don't release this because if you release this, it will all slip in. Now, this is the surgery that you do. So if it is gangrenous, you resect it first and then you allow it to, either you make anastomosis here or you go before. Coming to the textures that you're trying to do, you're trying to drive this in. So if you succeed, the neck would still remain constricted. So you will be pushing this inside the abdomen with the ring at the neck. So that's a ring and you're still inside. So what have you done? You've shifted what was in the scrotum into the abdomen. You've not reduced the hernia. You've reduced it en masse as it is. That's why it's called reduction in mass. Chetan, you understood? If you understood, right there in the box. Next question is quickly, should we routinely be done in hernia? No. Next question, I've done that. Now the question that is being asked is, let me finish the questions above, then I'll get to the question below. Because they're constantly adding now. Let me take hernia first. Anyway, I'll take it. Won't the field of a thyroid become granular? This I've answered. This was by Priyanka. So that I've answered. In Hashimoto's, it becomes little on the harder side, mind you. The section of recurrent cervical is stable graph. That's the correct answer. So perhaps voice is lost here. We got that fixed. Lump is better palpable than seen. Somebody said it correctly. Taxes will push constriction inside abdominal cavity. Somebody had written that correctly. Now, there are more questions, but I'm not able to go down here. I can now. Omentocele or androcele words are used only for inguinal hernia. You can use them anywhere. Omentocele means omentum, but how you swear by it in the ventral hernia? You can't. Omentocele or androcele basically simply indicate the content. So no big deal. It doesn't change anything. Akash Shinde. So Priyanka, you can use the term, especially in inguinal hernia, it's easier to use that term. In ventral hernia, it is not easy to use it. No, you don't know. Botox incision before planned large helpful incisional hernia. There's Akash Shinde. It is not that we find it very handy and not many people use it. It doesn't relax the muscles the way you wanting it. Then there's a question. No Texas in inguinal hernia also. Yes, no Texas. I'm repeating. Who was this? Priyanka. No, Priyanka has answered. Adam Talat. No Texas in irreducible inguinal hernia either. Yes, no Texas. Usually this story happens with inguinal hernia only, that you make a helicopter out of the patient, foot end up, head and down, arm hanging by the side, and you going to sleep. Not to be done. I think there are no more questions. If there are any questions, you can type quickly. Let me take the thyroid questions. More or less done. I think all questions are answered. I'll take the YouTube questions now. Can't eye sign-like proptosis occur in hypothyroidism due to retroorbital deposition? Very rare, but can happen. Prashant Kumar Singh. And if there are any more questions, definition of swelling versus lump. I've already answered that. Then Shivam, developed in a cold nodule. Yes, malignancies develop mostly in cold nodule. You're right. That Hashimoto's, I was just giving an example. It's not always the case. And somebody had answered it nicely. Now I can read it. Microcalcification, more of solid content, taller than wide. That is Priyanka. Very obvious. Good answer. Again in weight. Direct message to. Yes. I think with that we can then conclude. I've never used Botox incision I've not seen it being used also. If somebody can use it, it must be over a period of time, Akash. It is not something that you do immediately and will naturally be for relaxing the muscle so that you can usually for loss of domain, etc., where the whole hernia, a lot of abdominal contents are outside. That's where it will be an issue. Okay, so I think that takes care of it. Any other question? Any question from you, Ekansh, or from Shagun? If there are no questions, same old story. Please write in the chat box that it's all done so that I know it's over and we can conclude the day. I hope you again enjoyed it as much as we do, as much as I enjoyed doing it to you. So please type in the chat box. If there are no more questions, then you're done. I can't see anything written here. Ekansh is written, others also should write so that I know it's done. All right, thank you very much. God bless you all. We'll catch up next time. Yeah, all typing now. Adam Dalat. Thank you. God bless you all.